In November 2009, LouAnn Hepp and Ian Buchanan, co-owners of Vista Diagnostics International, were invited to participate in a malaria prevalence study on Watar Island in Indonesia. Vista Diagnostics donated unpackaged malaria tests, which were then packaged in Indonesia by Lab Hepatica. The Watar project provided logistical support and drugs for treatment of malaria. The first goal of the study was to assess the prevalence of malaria in the north coast villages of Watar, an island located in eastern Indonesia. Watar's population of 7,000 live in 23 villages scattered along the north and south coast. Because of Watar's mountainous terrain, there are no roads that connect the villages. Travel between the villages is only possible by boat, which is difficult during the monsoon season. There are no municipal services on the island. The second goal was to identify the asymptomatic carriers of malaria using rapid diagnostic tests, or RDTs, to help prevent the spread of malaria during the monsoon season. Typically in remote areas, diagnosis and treatment are based on symptoms alone. But by utilizing good quality rapid tests, all villagers infected with malaria could be easily identified and treated, thus breaking the cycle of infection from mosquito to man to mosquito. The third goal was to assess the effectiveness of using RDTs in the field, specifically PLDH tests developed by Vista Diagnostics. These tests detect a vital enzyme, PLDH, that is only present in living parasites. The tests used identified the two most common types of malaria, Plasmodium falciparum and Plasmodium vivax. The final goal is to attain attention and funding from the Indonesian government Ministry of Public Health, as well as foundations and NGOs interested in malaria eradication in this part of Indonesia. Indonesia is made up of more than 17,000 islands. Its tropical climate is a perfect breeding ground for 20 different species of malaria-carrying mosquitoes. Although there are 5 different types of malaria found in Indonesia, falciparum and vivax are the most common. It is estimated that 38,000 Indonesians die yearly of malaria. The Watar Copper Project on Watar Island is operated by PT Batu-Atua Tembaga Raya, which we will call Batu-Atua for simplicity. Besides mining, Batu-Atua also finances a community empowerment project on the island that currently provides services to the 2 closest villages to the mining camp. Services include school scholarships, financing for school supplies and English classes, microfinancing, construction, income gathering programs, and free access to the company's clinic. The mining company and the Ministry of Public Health provide additional health care, medicines, vaccinations, and health education. Community healthcare workers from the village volunteer their services after receiving training as part of this agreement. The project's manager, Mia Sonen, and her public health assistant, Ramdan Iskander, were responsible for organizing the malaria study. Travel within Indonesia can be difficult. For many, it is costly, time-consuming, and risky. Public boats are overcrowded, unclean, and often break down while en route. Most of the remote islands have no airports or landing strips. Travel to Watar Island is no exception. If all goes well, according to plan, travel from Bali takes at least 24 hours. For the malaria study, this included a plane ride, an 8-hour car ride, and a 15-hour voyage on a Batu-Atua-owned boat. The first practice run for the team was in the mining camp. The team had a chance to work out the glitches in the testing procedures before beginning testing in the larger and more chaotic village settings. This included performing a second round of tests on the positives using RDTs donated by Lab Hepatica to check the validity of results. The community healthcare workers learned quickly and demonstrated both compassion and accuracy in their work. The first large village was reachable by road from the mining camp. Upon arrival, the community meeting hall was full of anxious villagers, including many mothers with their young children. They know firsthand that the majority of deaths from malaria are among children age 5 and under. Here, as in other villages, there is much anticipation and cooperation. At the registration table, people signed for consent, were asked a brief medical history, then given a number corresponding to their name on the data sheets. This number was written on the back of their hands, then on the test cassettes at the testing table. Lancet holders were used for finger pricks, which helped decrease the fear of needles and improve efficiency. Still, it was often difficult to get enough blood for the test because of calloused fingers and anemia. Being surrounded by children made their other health challenges clear: tuberculosis, respiratory infections, malnutrition, and diarrheal disease. Although the goal was to test everyone in each village to make sure that no invisible reservoir of parasites was left untreated, after 2 long days, only 230 out of the 411 people living in the village were tested. This proved to be the case in other villages as well. Superstitions, misinformation about malaria, and absence due to fishing and travel to other islands all accounted for this. Later, the team's public health worker interviewed a village leader in a more distant village reachable only by boat. It was disclosed that villagers often believe that malaria comes from drinking the milk of green coconuts and that soapy, the locally distributed alcohol, will suffice as a fast cure. It was also discussed that many believe that malaria is similar to influenza and that it comes and goes without treatment. The village had expressed hope that cooperation between Batuatua and the health authority would provide bed nets and ongoing testing and treatment for malaria. Their appreciation and hospitality was demonstrated by serving food, coffee, and tea. When the testing and retesting phase of the study was completed in each village, the team returned to dispense medication to the community health workers so they could supervise treatment of positive cases. At the end of the first phase of the study, only 4 villages were tested and offered treatment. Of the 656 people tested, there were 94 positives, many of whom showed no symptoms of malaria. This meant that the average number of people carrying malaria parasites was 14%, varying from 4% to 24% from village to village. Of these cases, 15% were falciparum, 67% were vivax, and 18% were dual infection. Children made up a high percentage of the total number of positive cases. The percentages of positives are expected to increase as villages farthest away from the mining camp are tested. From this experience, the following conclusions were reached. RDTs are reliable for accurate diagnosis in remote villages where microscopy is not available. Village community healthcare workers can easily be trained to use the tests appropriately. PLDH tests, which detect only living parasites, should be used to monitor treatment effectiveness. Testing is time-intensive. It is impossible to test all villagers at a given time, so therefore testing needs to be an ongoing process. Amodiac, when used in ACT for malaria treatment, often makes people feel more ill than their asymptomatic malaria, so full treatment is sometimes rejected. Therefore, treatment must be monitored. Education about malaria, its causes, treatment, and control is a key component to any eradication program and must be supervised by village leaders and healthcare workers. The Watar experience was both powerful and enlightening. There are so many health challenges that require attention. Although private companies, foundations, and NGOs can assist, there must be a firm commitment from the local government's Ministry of Health, along with cooperation from the village leaders to support long-term progress.